Thank you for everybody for coming along. For those of you that don't know us, we're from the Adult Autism Services in Shropshire, Telford and Wrekin. My name's Mary. I'm the operational lead for the services. We're three pathways. We've got the largest pathway is the Autism Assessment Service that covers Shropshire, Telford and Wrekin, and then we've got two smaller pathways, the mental health pathway and the autism forensic service, which Dale is the team lead for. Dale and his colleague Sarah have done some work relating to their referrals, and then have linked in with Gulshan from the research and innovation team. So Dale's going to talk to you about all that.
Thanks, Mary. Hi everyone, my name's Dale Taylor. I'm a mental health nurse by background, and I've been the lead for the autism forensic service in Shropshire for about 7 years now, I think. Prior to that, I worked in safeguarding, so that's my background. My colleague Sarah Cabot is also a mental health nurse, and she can't make it today. She managed to get out of this, which isn't fair. So if you do watch this, Sarah, that's most of this work is her work clinically and her research. So she's a mental health nurse, like I said, and her background is working on forensic secure wards, doing autism assessments as well with our service, and she's been with us for nearly 4 years. So she's got loads of experience, and we've also got Nazia here.
So yeah, I'm Nazia. I'm an assistant psychologist. I work in the autism assessment pathway, so adjacent to Sarah and Dale. And I'm involved in the project just because I'm helping with the write-up of the research that Dale and Sarah have done into more of a formal report. So yeah, but it is all their research.
And you've got loads of experience as well, Nazia, with autism assessments, so doing ADOTs and ADIRs. And we'll talk about, actually, we get lots of referrals for autism assessments for patients who have got a forensic risk background. So we have a bit of back and forth. And Gulshan.
Thank you. So hi everyone, those who don't know me, I'm Gulshan, and I am a research associate here at MPFT's R&I department. I'm also an honorary research fellow at Keele University. I'm currently working on a project which is evaluating compassion-focused therapy used with women on perinatal pathway in prisons, and I'm also working to extend research engagement initiative at MPFT within the learning disabilities team. And I'm passionate about research involving people with neurodiversities, learning disabilities, and have their views collected using creative methodologies. So I'm here today to basically highlight the support that R&I can offer to staff who are keen on developing research, as well as talk a little bit about, I think most talking is going to be done by Dale, but just to say that what we're going to do with the piece of research that they've already done. So as you can see on this slide, why research matters in healthcare. It's not something very new. We all know that research leads to better diagnostics, therapies, care pathways, and it also encourages new technologies, medications, and clinical approaches that basically shape healthcare and healthcare decisions at all levels. So if we just look at why clinician-led research is even more impactful, so very simple reasons, because clinicians understand real-world challenges more and patients' needs more as well. Research basically coming from them is grounded in everyday care experiences, and that is why findings are more likely to be applied in practice too. And not to basically forget the trust elements when the research is coming from the clinicians, basically that trust which is there, that is really important too. I will pass on to Dale back, who will share his and Sarah's amazing piece of work that they've conducted, a great example of how clinician-led research is shaping or can shape basically the future of healthcare. And this piece, I must say, that it's not only impressive, but it's incredibly important for all of us here today in this meeting, because I'm sure we have some interest in the area about which Dale is going to talk about. So over to you, Dale. Thank you.
Sarah and I have been working in this team for quite some time. So a bit of a background for our team and what we do. So our priority is supporting autistic people to be discharged from secure hospital, and we work with patients, kind of managing their conditional discharge, rather than, I suppose, the first team that may manage patients with schizophrenia. We work with people with autism only, so that they also have some mental health problems, and anxiety is quite common, but autism is the primary need. We also work with autistic people in the community informally with their consent. We get referrals from probation, police. We've got a really good sort of relationship with the local police service in Telford in particular, but also adult social care, community mental health services. And we're based in Hazeldean House in the Autism Hub, but we also work with people at home, or we meet people in probation or police stations as well. And we work with people after they've had a conviction, and people tend to be a bit more willing to reflect on things after the conviction has happened. We've got a bit of a structure where we work with someone on something called a collaborative safety plan, which is improving their understanding of autism. We talk sort of 6 sessions. The second session is about the person understanding their convictions, and then the third session talks about why they did it, the circumstances, and then we try and make a bit of a plan to reduce the risks of that happening again. It's really very basic, and you'll see themes throughout this that this research is quite basic as well, and a lot of it's common sense, but essentially we give autistic people who've committed an offence a chance to talk about it and reflect on it. We also give advice, guidance and training to other agencies, including probation, police, adults. Prisons, we work with the OPD pathway for patients that are autistic in prison, and there's been a bit of a worry about them being released. But the majority of our work is with autistic people in the community with their consent. So our sample size, and this started off as a back of the envelope research. I am no researcher. We like to notice when you're in a team meeting, you think, goodness me, there's another patient that has that background, or goodness me, there's another person from that area. And I think with clinical experience, you notice that the same thing happens. Like it doesn't repeat, but it rhymes. There's themes, and we decided to have a retrospective study with a sample of 30 patients from 2022 to 2025. All of these patients have a high IQ, so they don't have a learning disability. They're all adults and mostly in a community setting. So we picked about 8 categories to go back retrospectively and see if we could find any common patterns and put it together. We presented this to our team, and then we've been asked by different people to present it some more. So this is what we found. So like neurotypical offenders, the majority of our offenders are male. We have 1 person that identifies as non-binary. We haven't had any female patients out of that 30, which is similar to the neurotypical offending population. It's mostly men in prison. It's mostly men committing violent and sexual crimes in the neurotypical world, and also with autistic people. 2/3 of our offenders come from Telford. I live in Telford, so I like Telford. It's got a real charm to it, but there are areas of poverty, deprivation, shortages of housing, drug and alcohol problems, industrial decline. It's a nice old, just like the valleys in South Wales, lovely old coal mining towns. There's lots of unemployment. So I think that's a fact. In Shropshire, people tend to live longer and have a better quality of life. And we sort of propose that their factors in offending for autistic people and for neurotypical people. So we put the types of offences into some sort of categories. Many patients have repeated offences. So one patient might have committed several crimes that cross these categories. And if we start on the left-hand side, there's quite a large group of numbers that the incident of family physical assault. We've got lots of parents and carers that are victims of assault as well as partners. The highest group of offences are sexual assault towards a child, and most of the victims in these cases have been somebody within the family network. So siblings, step-siblings, children, stepchildren, cousins, that sort of family network crime, which is the same as the neurotypical population. There's quite a large group of patients with convictions for online images of children. We've got quite a close relationship with the sex offender team in Telford, and we went through quite a spate of referrals from them. We had lots of referrals for autism assessments, essentially, and the forensic team, participate in the autism assessments with my colleagues if we get a referral from the police or probation. One person is arson. That was quite a serious incident. A bladed weapon. We've got 2 patients with knife crime, but they didn't assault anybody, but they were caught with those. We've got quite a large number of firearms offences compared to bladed weapons. And being in the West Midlands, or pretty close anyway, myself and Sarah talked about this quite a lot, and you'd expect bladed weapons to be higher and firearms to be lower, but we sort of proposed, and we don't know, we're just guessing, that the bladed weapon offences are quite often in like gang-related crimes, maybe drugs, possibly like self-protection. You see shorts on Facebook and kind of on the news and stuff of young kids in the West Midlands carrying machetes and all sorts of stuff down their tracksuit bottoms, and that's not the types of offences that our patients have kind of been convicted of. So in gang culture, not that I'm an expert on that, but it requires a social network. So you've got a hierarchy, you've got teamwork. It's a team culture, and our patients are all autistic, so our patients don't particularly fit within a gang culture. We do have some, but the majority of our patients who've committed with a weapon have actually bought stuff online. So they bought guns on the dark web. One chap's bought a gun from America. We've got patients who are really into like this airsoft thing, and there's one near RAF Cosford, isn't it? The sort of paintballing, and they quite often have all the fatigues and all the gear. And in the 80s in South Wales, you could walk around in army fatigues with a shotgun, but you can't do that in 2025 in Telford, unfortunately. Well, fortunately. So quite a few of our patients have been raided by the firearms department. There's no such thing as a naive offender. So all of our patients these are convictions. It's not sort of an accident, if you like. So I'll move forward. There's some other sorts of violence. One patient is kidnapping, robbery, criminal damage. We've got one patient currently with prevent, and we've got a new patient that isn't counted on here. That's also with channel at the moment. Again, it might sound typical, but our patients spend a lot of time on their own. They're quite often unhappy, and they're quite often on the internet, and they are vulnerable to being radicalized. They're vulnerable to being part of these incel sort of type groups. They're quite lonely, quite marginalized. Not that we kind of sympathize with these things, because they've committed pretty serious offenders, and we've got to prioritize the victims and safeguarding, but we're just trying to understand why they've committed these offences, get them to reflect on it, and try and reduce their risk to having a bit of a better life. So age range, The majority of our patients are 18 to 25, as you'd expect with the neurotypical population. It is a chaotic time of life, and it's quite a emotionally distressing time if you're not in university. Well, it is if you're in university as well. But if you've got no direction in your life, if you're lonely, if you're young, there's an enormous amount of pressure on people in their 20s to get a job, get a flat, get a partner, start settling down, get an education. And I'd say 90% of our patients are not meeting those comparative milestones that they compare themselves with people. But the neurotypical population, most offenders are in that age range as well. This reduces, we've got patients who are 40 plus who committed their offences when they were in their early 20s, still on Ministry of Justice conditions. For patients that commit a crime, a serious crime, they'll go to court, and sometimes the judge will send them to prison. Sometimes they get a probation community sentence. Sometimes they'll have a bit of both. Occasionally, somebody will have a hospital order instead. I'm sure you all know this anyway, but that hospital order might be a Section 37 within our trust. So it could be in St George's or Clee, for example. Quite a few of our patients go to an autism specialist unit in St Andrews, but we've had patients in quite a few different units. And what do you treat an autistic person for? Because it's not a condition that you can treat with medication. So our patients tend to stay there a long time. And the creation of our service in 2018 was because a patient was a delayed discharge, having been kind of stuck in hospital for 20 years. So diagnosis, this is, I mean, I find it all interesting, but this is interesting. So around 2/3 of our patients were diagnosed with autism as adults after a conviction. Nazi, I thought maybe you wanted to talk a little bit about autism assessment and what the team do and how we manage maybe a forensic referral from the police.
Yeah, so this is sort of where I fit in because I work in the adult autism assessment pathway. So anyone that's over 18 who's seeking an autism assessment. And those people, they might have self-referred after doing their own research into autism, or they might have been referred by other healthcare professionals who've been involved at some point in that person's care. We do also sometimes get referrals that are put in by other professionals. So, for example, police offender managers or mental health liaisons that might be working with an individual who might have needed extra support during their encounters with the justice system, you know, at different points in that process. So yeah, and obviously autism has been around for a while now, but our understanding of it as a condition tends to keep growing. And so we're learning a lot more about different presentations of autism. Some of those presentations, you know, they possibly could have been missed in individuals when they were children. So that might be one of the reasons they're seeking answers only as an adult. There are lots of other factors as well that kind of impact individuals only receiving a diagnosis as an adult, which includes overall childhood experiences, which I know Dale's going to talk about. Sometimes there's just a lot of uncertainty or chaos within the settings in which people grow up, which means that, you know, assessments for a condition that, yeah, they're just not always on the radar. And I think that goes hand in hand with some of the risk factors for offending behaviours, you know, those adverse childhood experiences. And yeah, so we take on individuals who are seeking those assessments. The assessment is kind of broken up into multiple parts. We take a multidisciplinary approach, and we speak to these people and we get to know them and yeah, see if an autism diagnosis is appropriate or not.
It's great we work together on it, like, you know, and patients don't want to keep telling their story again and again. And what I like about it is, like, I did an ADOS with a patient a few weeks ago, and you're doing an ADIR in a few weeks. So as part of an ADIR, you get the developmental history. So we're like really lucky because we get to know what happened with this patient What was the,
Yeah.
what was their mum's pregnancy like? What was birth like? Did they have any speech delays? Any delays with motor skills? Did they get on with other kids from nursery? Did they have any difficulties in primary school making friends? What was secondary school like? Did they go to college? And you're like, if you go chronologically, there is always a path to the offence that happened.
Yeah.
It's almost like a recipe, which is great that we can be part of the autism assessment as well. And then we talk with the patient about it afterwards. In the NHS, services for assessment and post-diagnostic support are quite often commissioned into different areas. So that's the case in Telford and Shropshire. We've got colleagues in CVS and Shropshire Autism Hub that will do post-diagnostic support. And that's ours is an equivalent of post-diagnostic support, but it's for forensic patients. And when nurses and psychologists in our team, we've got a clinical psychologist, we've got a consultant psychiatrist as well, Dr. Pravin, that works with us half a day a week. So it's kind of a pathway for different people, but it's good being part of Nazia's team and with Mary and Dr. May. And one thing we thought is that if you go through your life as an autistic person and you're having these difficulties with communicating and interacting, repeated behaviours, difficulties with change, sensory problems in school, probably bullying as well, and you didn't know that you're autistic, we sort of hypothesised that if that person knew they were autistic as a child, at least schools would have been able to put some support there, give them space to talk, make reasonable adjustments. But this 19 missed out on that. And I think that adds to your life stresses or your adverse childhood experiences, which we'll come to next. So 27 out of the 30 of our patients have had at least 2 adverse childhood experiences. And you all know what these are because you're all mostly mental health professionals, but some examples of parents who are also autistic perhaps as well. Not that that's an adverse childhood experience, but parents will be having difficulties with communicating and interacting in their own lives by the definition of having autism. So it is a stressor. It doesn't mean that they're not capable parents, but they have their own extra challenges, I think. So our patients, there's quite a bit of domestic abuse that they witnessed as children, substance misuse, parents in jail, abandonment, child abuse, bullying. Bullying is huge. We work with Marilyn quite a lot, and I'm sure she won't mind me quoting here, but I do recall her saying, so Marilyn's a patient, an expert by experience that works in Shrewsbury in the autism hub there. Does a lot of training. You probably know her. And I remember her saying she doesn't know one autistic person that hasn't experienced trauma in the form of bullying or social kind of rejection. So it's quite common. So difficulty with housing, which we'll come on to. Diet, health, poverty. Yeah, especially in Telford, but also in Shrewsbury and Shropshire as well. And discrimination. So our patients have had at least 2 of these, most of them, particularly bullying. So housing is a major problem. So out of 30 patients, not one of them has got a nice 3-bed semi in the suburbs. They're all living in difficult, overcrowded, unstable accommodation. And it's definitely not a psychologist, but the old Maslow's hierarchy of need, at the bottom is shelter. So 6 of our patients living in HMOs, so houses of multiple occupancy. Quite often, if they've come out of prison, they get accommodation with yellow ribbon. And autistic people living with other offenders who often have their own challenges and are often neurotypical, loud, drinking, chaotic. It's pretty stressful. 4 patients homeless. We've got patients in Telford where they're living in their mum's shed because they've attacked a parent, and the parents don't have the heart to put them on the street, but they also want to, you know, they're not safe to stay in the house, so they're living in the shed in the garden, or living in a hotel, or so there's a massive shortage of accommodation, and I think this message would be quite good to share with colleagues in adult social care, commissioning, school, and all that. One stage at a time. We'll see how we get on with this today first, but housing is a major problem for somebody who just wants peace, quiet, stability, consistency, sameness, doesn't want change, doesn't want loud noises. You can see how any of the first 3 would be pretty awful. Just over half of our patients still live at home with their parents. And if you remember a few slides previous, parents are often victims of offences. So that obviously is dangerous. We quite often get referrals from clinicians that have tried supporting patients to get out of the home, but parents quite often don't want to press charges against their children. And I remember a colleague saying a few years ago that if patients attacking their parents, it's entirely likely they were doing that as children, and you can cope as a parent with a 6-year-old, you know, having a meltdown and lashing out, but when they're 16, it's a lot harder. And also, people don't know that they're autistic, or families know they're autistic, but they haven't received a diagnosis yet. There's enormous waiting lists for children's assessments for autism, and as a result of that, for adults. I think it's, I don't know off the top of my head, but I'm sure Mary and Nazia could find that out. But it's a lot. Drugs and alcohol are factoring over 3/4, so patients consuming alcohol. Many of our patients tell us that alcohol helps with social anxiety, and it does. You know, it can. You know, I can certainly remember being 18 and having a couple of pints before I go out, just to feel confident. But people do it every day, starting in the morning, and I think that's a different kind of level. So yeah, the majority, but not all, of our patients also use drug and alcohol regularly. Is it because of the autism? So we quite often get this question. Last week I had an appointment with an intervention provider in Channel, and he said, I'm trying everything I can, but he's autistic, so he just won't listen to me. That's what my colleague said. And actually we wonder, you know, is that the case? Is it because of autism? Is that why people are offending? And what we propose, you know, it's a factor. I remember qualifying as a nurse and having absolutely no clue about formulation or psychology, and thinking people just had these like conditions that you could give medication to, and having spent time with Dr. May, other colleagues who are psychologists, and understanding about formulation. I wouldn't say I understand formulation, but it's absolutely what it's all about. I think, you know, formulation and making it accessible for nurses as well, to understand what formulation is, like autism assessment, like formulation. These are all, like, when I just qualified, these are all things that psychologists do, or psychiatrists, not nurses. But there's no reason we can't, as like nurses or OTs or allied health professionals, get specialism in this stuff, because we've got loads of clinical experience. We just need to have a bit more confidence in trying it. So I blather on, but similarities to neurotypical offending. So most patients are male. Well, they're all male in our case, but in neurotypical offending as well, most offenders are male, who also have 2 or more adverse childhood experiences. There's a case for loneliness, poverty, and our offenders tend to offend when they're younger, in their early 20s, But also from 16, we don't work with patients who are under 18, but the youth justice also have a high caseload of autistic people and people who they suspect are autistic but haven't got a diagnosis yet. The differences for our population are that autistic people are more likely to be victims of trauma than perpetrators. So in the general autistic population, autistic people are more likely to be victims of abuse than neurotypical people. All of our patients, by definition of having autism, have difficulties with communication. So that's, you know, forming the words and actually making the sounds and the listening and the reciprocal conversation, and then the interaction as well. So interacting in groups, with friends, with probation officers, with health, with adult social care. So a lot of professional service, we rely on our ability to feel a bond with our patients. So we might be trying to build up rapport, whereas lots of our patients can't do that. So there is a challenge for housing officers, social workers, nurses, everybody in and not relying on building a rapport to make progress with a patient, because autistic people sometimes struggle to do that. Quite often our patients, or all of our patients, have got repetitive behaviours and interests, difficulty with change, insistence on sameness. Quite often our patients are very pedantic about timekeeping. So I've seen a patient in particular, I think for 7 years, and I've seen the same time, the same place, and I've never been a minute late because he couldn't handle it. It's not worth the stress for him. So it's about us rechecking on what you can expect. Actually, don't you know, us going into it to making it as easy for the patient as possible. They all have sensory difficulties, quite often sound, light, touch, clothing. This is particularly difficult for patients if you imagine being in prison, pretty awful environment. And patients are actually, some of our success stories have been when patients have been released from prison, they really don't want to go back in quite often. So they come to us with motivation, with consent to do some work to enable them to keep out. So they're quite motivated quite often. Not all, but quite often are. Most of our patients are diagnosed post-offence. None of our patients live independently. Half live with family, some of which are victims of these offences. So a formulation approach is best. We got a really great team, 2 nurses. Bex has just started 3 days a week as a psychologist, and she's working in prisons. But we've got a really brilliant wider autism team, and like really supported by Mary. So we've got real chances to like talk about our patients and reflect on things and think about autism, but also think about all these social factors as well, put it all together. And yeah, we have some good results. So it's the importance of safety, supervision and safeguarding. We receive regular safeguarding supervision. That's really great from the safeguarding team. We discuss team cases every week in our team meeting on a Thursday. We use the Shropshire Forensic Liaison Scheme because I think it's always good to get a fresh set of eyes on a perspective. So we use them for patients that we're struggling with, or we're stuck with, or particularly high risk. So we'd ever feel that we're experts, you know, well, you know, we're pretty specialists, but we always like to get scrutiny from other people and supervision. So psychology, formulation and reflection are really important, and that's something that we do as a team, but also with our patients. I think we spend a lot of time listening and getting patients to reflect on their ongoing fallings out with neurotypical people. We spend a lot of time on the phone listening to them in a bit of a wobble moment, and rather than them going back to setting a fire or assaulting somebody or going on the dark web and ordering a gun or goodness knows what, they can talk with us about it, or we can book an appointment to talk about it, and it just puts a bit of a delay and an opportunity to reflect and think about the decisions rather than, you know, it being instant. And over time and maturity, that's a good effect, you know. So that's essentially our bit of amateur research in our team, things that we've noticed, factors that rhyme but don't necessarily repeat. And it's been really great having Gulshan, because she's encouraged us to, I suppose, be a bit more confident in our own research and sort of put it forward a little bit, promoting research across the trust, and Nazia as well, trying to organise it into a sort of paper. But that is not my. I'm more of a clinician going for a cappuccino and a chat with somebody rather than a researcher. So I'll leave that to you, Gulshan, to explain.
Thank you, Dale. Thank you. I don't know I'm going to be able to do any justice now following your great presentation, and what a great piece of work that you and Sarah have done in your own time. I think you forgot to mention that. And as you said at the start, you always underplay it. Honestly, it's great. And you cannot say anymore that you are not a researcher, because you've done this great piece, a great example for so many staff members, so many colleagues to follow. So thank you so much for sharing for that. And just a little bit now, I won't bore everyone by going into a lot of details, but R&I here at MPFT basically oversees all research projects across the trust. So our role is to promote and embed a positive research culture, making sure that it's part of everyday practice. We manage things like portfolio, including academic research, NIHR delivery partnerships, governance, service evaluations, innovation, patient and public involvement, sponsorships, and not forgetting our research buses. I'm sure you, most of you would have seen on social media our research buses as well. So R&I works alongside clinical teams to deliver national and local research studies, ensuring that staff, patients, carers, and communities, they all can get involved. And we also provide governance and ethical oversight, so making sure basically that all research is safe and is robust as well. We partner with Kiel and other academic institutions through our academic groups in rheumatology. Just the previous slide, Dale. Thank you. And our academic groups in rheumatology, mental health, social care, public health, community and primary care as well. So importantly, we provide training and support. So next slide, please, Dale. And as you can see on this slide, it's about STARS. And I really hope that you have seen this before as well, which would mean that you've attended some of the STARS sessions. This is our award-winning STARS program to build research skills and help staff bring evidence into practice. It's free online research training. It's delivered by the MPFT R&I department in partnership with Kiel and Worcester University. The sessions are run throughout the year on Teams, and they include both workshops and seminars. I won't go into details of workshops and seminars, but there are three key aims. First one is to build a positive research culture. Second is to help staff apply the latest research evidence in practice. And final two, support future research leaders in health and care. It's open to all staff, whatever your role or your level of experience is, whether you are new to research or looking to build on what you know. The program basically offers practical tools, knowledge, and support to anyone who is attending. You can learn by attending these how to evaluate service improvements, carry out a literature review, support or lead research, publish your findings, or even explore funding for innovation or evaluation work. Now with Dale and Sarah's work, we are going to create an academic publication from the data collected as well as the talk that Dale has just given. Nazia is also on the team, so it's great that, you know, once this is progress more, I'm sure Dale will share with you all, and we look forward to hearing. And if we can support any of you in doing something similar, please do get in touch with STARS or R&I. There are all the contact details here. So yeah, over to you, Dale, again. And sorry, one thing I have not put on the slides, but there is another opportunity for staff members to apply for internship program. I will put that in chat for anyone to see. The deadline is really short. If you haven't come across, feel free to get in touch with me or the email address on the poster that I'm going to share in chat. So over to you, Dale. Thank you so much.
Thanks, Gosh, and I can't thank Goshen's team and Nazia's and Sarah enough for like pushing it. And I think, you know, I'm not a researcher or somebody whoever wanted to do that sort of stuff, but it's having talking about your team, what you do, what you're interested in, and it might just sound simple to you, but it's actually quite interesting to do and get your support and see how it goes. Mary's put in the chat the NHS England data referral waiting times, and it says that there's 236,000 patients waiting for an autism assessment. So that just goes to show, you know, that there's an enormous need for more funding for autism assessments for children and for adults, and the relief that patients get when they get an outcome, whether it's yes or no, it's a huge, you know, experience for them, and it's a privilege to be able to do that. We have finished our presentation, and we wondered if anyone had any questions or comments on anything.
It's fascinating to hear, actually. I don't know if you can hear me all right. It's really, I work in the drug service here in inclusion in Andover, and we're seeing more and more autistic people coming in as part of the CGIT team, but also as part of sort of walking in looking for some support. And more our people are struggling with, or saying that they're struggling with autism, and their addiction is part of it. And that's something, as a recovery worker, I don't have a lot of training on how we support autistic people in addiction, because it does seem that the neurodiversity and addiction go hand in hand, but the pathways are not as clear or as effective as they could be.
That's really interesting. I remember working with a colleague who was in a drug and alcohol service in Hereford, and he used to tell me about the routine, the ritual of going to purchase drugs and making it, measuring it, and then administering it is very structured, repetitive. And yeah, I mean, I don't know the links or the research in that, but it does sound interesting. And but I mean, our team's really approachable. If you ever want to, I know you're all the way down there, but I'm sure we can, you know, if you ever want to come along to our sort of, yeah, our huddles or our training or something like that, we could talk about where you can access more information about autism. What do you do, Jess? You a nurse or?
No, I'm a recovery worker, and in fact was diagnosed with ADHD and autism myself last year. So,
oh, wow.
So
well, you know a bit about autism then.
I do indeed. So, yes. But the links between substance misuse and neurodiversity and the treatment pathways seems to, I think, could do with a little tweaking to make it a little simpler or easier for staff to be aware of, but also for the clients and patients themselves to have a more successful outcome.
Sounds like you've got a research project on your hands then, Jess, with
If only I had one day.
neurodiversity and drug use, because that's how you start. You notice things, and then you have a chat with Goshen, and before you know it, you're doing this. So maybe that's the best way to do it. You know, if you notice things, and then you kind of write it down, I guess.
Well, pattern recognition is a particular fascination of myself, and so I do recognise it in lots of the clients that come in, and they are beginning to recognise it themselves. And we're talking more and more about neurodiversity, but we're not necessarily recognising it in recovery practices.
That's really interesting. And drugs and alcohol help with anxiety initially.
Absolutely.
Initially, so you can see the some links there, yeah.
Mm.
But unfortunately, they come with a huge amount of side effects and stresses
Exactly.
as well. Lovely. Any more questions, or we're ready to close? Oh, go on, Melanie. Sorry.
Hi. Yes. I'm a recovery volunteer also for Inclusion Drug and Alcohol Services. I've actually met Jess from Andover, so she might recognise me. But I just can concur really what Jess has been saying. I mean, my experience, because I was also a previous service user. That's how I came to Inclusion Services in Hampshire. But I have, and since I've been volunteering now for nearly 3 years as a recovery worker, I have noticed that and picked up on it that many of our clients that come into the service have a lot of them have either a late diagnosis of autism, or they haven't been diagnosed, but and they're unsure whether they have autism, or in particular ADHD, that seems to be very prevalent. With once you what they're finding is they're getting a dual diagnosis at the same time, as in Jess, and many clients that I've met and service users are saying, are finding that it's very common. And you probably find that with your patients as well, that there's a really strong connection with ADHD and an autism diagnosis as well. Yeah, it's something that we're finding more and more as and when clients actually register, or they're referred to drug and alcohol services. So yeah, it's something that I think would be really good to sort of, as you say, perhaps a new research project, and also some co-volunteers as well have been diagnosed on the autism spectrum as well, but they're also and you have to be so mindful of that when you work with them as well. I've been fortunate enough because I actually worked for the Priory for nearly 4 years in the children's educational services, and I worked at a school purely for children and teenagers on the autism spectrum. So I was, from an educational point of view, from a young age, from 6 up to 19, they were in residential accommodation. So I've had a fair bit of training, and all the links that you mentioned earlier on in your presentation, Dale, they're also, I was listening to you, I was thinking, oh my God, that is so,
it sounds obvious, doesn't it?
Yeah, it's so obvious.
Most of it is pretty obvious, yeah.
And then, of course, they have other mental health anxieties as well. That's really all connected. So it all comes under that one sort of umbrella, and starting from such a young age as well.
Yeah, when you're first having difficulties interacting, and that's the thing with autism, people quite often notice it at milestones. So when you start in nursery, the ADR focuses on the age of 3 to 4, because kids go into nursery in a group and start playing, Ring a Ring of Roses, and actually one of the children doesn't want to do that. They want to stay by the teacher. And
Yeah.
not saying that's the criteria, but that's the age to start noticing. I'm just conscious of the time, and Donna's got a question, and then we're probably going to wrap up. Thank you.
It's more of a comment, really. I guess kind of I'm also from Inclusion in Hampshire, and I guess I just wanted to make the other people aware that there is some inclusion training specifically on working with substance misuse and neurodiversity, and just talks lots about the language we do and kind of repeating and kind of writing notes and things that kind of people can refer back to.
Oh, great.
so
I'd like to do that.
Yeah, have a little look. It's in the MPFT prospectus, which I know is trying to cover kind of huge amounts of ground with various different services. And it doesn't give you all the answers, but it certainly gives you some pointers in terms of kind of, yeah, that repetitive stuff and how you can communicate more effectively. Equally, autistic people tend to, if you ask the right questions, they will tell you kind of what's going to work for them. So I guess just bearing that in mind.
Yeah, you're right. You're right. Yeah. If you're able to listen and give someone the time, they often have got an answer. You can be very honest. We get it wrong as well, which is quite refreshing. Lovely. Well, thanks very much. That's the end of our presentation. And if you do want to get in touch with us about, autism training or talk about patient or I guess researchers, Gulshan's team, and we might not have an answer for you, but we can certainly point you in the right direction for which courses to get on if you're interested in autism assessment and diagnosis. And thanks, everyone.
Thank you, Dave.
Dale.
Thank you all.
Thank you, Nazia, Gulshan.
Thank you.
Thank you.
Thank you so
Thanks,
much.
everyone.
Thank you to Sarah as well.
Thank
who's
you.
absent.
Thank you, everyone.